Thank you. Welcome, everyone. I was moved by one of the phrases yesterday when we were thinking about long-term care. And institutionalization and deinstitutionalization were mentioned. They both sound bad, and they were in a dichotomy. They're opposed to each other. And a good attempt to approach this issue, obviously not to solve the issue, will be to use an example on dementia with various origins. Because the work that Poland has been participating in very intensely concerns the latest 22-something years since the 80s. We've started, and then we've been working hard in the attempts to implement to the Polish system a certain system that would meet our cultural and financial requirements, but also be based on the latest ideas from the West. Hence, this concept of using an example of dementia and long-term care. Just to quickly remind you this in a nutshell, we all know this as practitioners, that every dementia takes many years to develop. When we have various ideas what to do, we always have to take into account this temporal dimension. When we are talking about prefrontal dementia, vascular dementia, Lewy body dementia, Alzheimer finally, but also dementia and Parkinson's disease. It all takes years to develop and has different qualities and features, which means that every caregiver, formal or informal, has to be sensitive about these differences and prepared for them. Here's an example of the course of Alzheimer's, development of Alzheimer's disease. This is something that's best tested and described. Starting with the initial symptoms, we see a disturbance in behavioral disturbance. You can try to correct it, provided you have the right tools for that. And we have educated caregivers operating in different places. In other words, we could say that if we have community carers, then we would capture these symptoms and we would support the loved ones or family members in their care. Then there's a lot of variability. We can see various mental disturbances or psychiatric or behavioral and psychological symptoms of dementia, when we also see psychotic symptoms. Now we're not sure where to treat them. The latest research shows that this should not be treated at a hospital. Across the world, these people are sent to psychiatric wards due to psychotic symptoms mainly, but this should not be a hospital. This should rather be a different place. And finally, the final stage with severe dementia, we see issues not only related to care, but nursing, feeding, physical care, incontinence, etc., plus infections. So each of these stages require a different approach. This variety suggested a long time ago that this should not be separated into two parts only. When you're in an institution with a skilled nursing facility of various kinds, or not in an institution. When you have the family, a caregiver, etc. This is not the right approach. We are still looking for the middle way, for the Goldilocks solution, so to speak. I will try to present this in a way. This will be nothing new. In Poland, this movement around caring for people with dementia is developing dynamically. We have excellent Alzheimer-related societies, but they also work with all kinds of dementia syndromes. We just need to adjust the approach to the needs of the patient and the caregiver. So we have functional stages that show us how long it takes for the dementia to develop, and that we have different needs at various stages of its development of the patient, and we should somehow get used to this fact. A caregiver is a person, a caregiver is the first caregiver, the main caregiver. That's a person that suffers from overworking. We've seen many books on that, lots of research on that. That's a person who is gyrating around the patient with a lot of anxiety, not really coping with unexpected symptoms, which are psychopathological. However, in Poland, research performed by TMS in 2016 mentioned that the workload for caregivers, depending on the intensity of the dementia, is from 42 up to 80%. Plus, there are some additional situations like family conflicts that are not mentioned at all in Western literature, but they are not described in Poland. And the greater the dementia, the greater the conflicts. So I'd like to mention a work from last year for a reason. It's a Dutch project, NDEM project. It shows that where the caregiver was supported by a whole network of connections, how much they managed to lower the percentage related to the load, so to speak. Only 22% when there's aggression and excitation in the patient do we have a large load of the carer. In 27 it's moderate, and half of the caregivers don't have an issue with that. Why? Because they receive support, organized, permanent, institutional support, and so on and so forth. Each of these positions could be discussed in detail. Anyway, the conclusion is, from the research, that the more we are supporting the caregiver as an institution, obviously building networks around a caregiver is also an institution, so the more we are supporting the caregiver, the less the person feels overworked and overloaded and desperate with with caregiving, and the easier it is to provide the care at home. So this is a division of what's happening at every stage of dementia. It's worth mention, apart from important components, the costs that are growing significantly, which are not refunded long enough. Even we have reimbursement of diapers for 6 months, for example. Dementia is much longer. Each of these stages, when there's incontinence or there's stool excretion, takes much longer. Another another argument against institutionalization is the fact that in the last 2 years we saw many results of research saying that if we take the patient away from the home and put him or her in a psychiatric ward, for example, in a psychogeriatric ward, for example, the course of dementia accelerates, it develops faster, and when the patient returns home, the patient is much less effective in communication and their everyday activities. They don't remember, they don't recognize their caregivers. So the caregiver receives an additional load. I mean, to sum up, in a nutshell, we could say that a hospital is not the right place for the patient. Just to give you an example, a few years ago, we saw an only PhD work by Dr. Ratajczak published, where he researched the relationship between the mental state of caregivers and their functioning. Without discussing this in detail, please note how often we see depression in caregivers, depending on the length of the care they provide. We have more and more somatic symptoms, so aggravation of the symptoms of disease of the caregiver. When they don't receive any support, they are left to fend for themselves. What are the predictors? That's obvious. I mean, the more psychopathological symptoms we have in the patient, the worse off is the caregiver. Why? Because they are socially isolated. There's no support of the community. They are just helped from time to time. So some of the caregivers, more and more often, go to psychiatric hospitals and they leave the patient there, explaining it with aggression and direct threat to their health. Or they just send papers to nursing institutions, skilled nursing facilities, or social care homes. We could reverse this trend, creating an alternative reality.
Polegałaby na bardziej zindywidualizowanej.
This reality would be based on a more personalized approach to this entire issue, also in other parts of the long-term care system. Here, some more examples of the worsening state of a caregiver who doesn't receive support, worsening mental and physical state. It's not just fear and depression, but we have 6-fold higher risk of dementia and that type of disorders in caregivers. And the picture is not very pleasant. Burnout syndrome is a very important component of worsening home care. The caregivers cannot cope, also due to the fact that there are symptoms of burnout, irritation, not listening to the patient. It is very often among my patients and their caregivers. They say, "Mama has become mean. She's doing it to me on purpose." And it is very difficult to explain to them that it is part of the disease. So what are the positive and negative aspects of care provided at home? In Poland, it's about 80%. We do not really know, because Poland is such a happy country that statistics simply do not cover some issues. So out of sight, out of mind. But it's between 80 and 95%. And obviously, it is a much safer environment in general, especially for patients with milder forms of dementia. It is a company of people they know, they see that person most of the time, so there's a feeling of security and stability. There is no harm or no trauma related to relocation. It is dementia is a state when the brain cannot learn new things. What about going to a hospital or going to a nursing facility or a care home? The brain cannot learn new things, so it's really bad for the brain, and that is why certain behaviors get more intense. And at the same time, the burnout syndrome, the accidental character of care, caregivers move from one Alzheimer patient association to another. They are not fully conscious. They don't know how to respond. If they have a physician, if they have a doctor, they can ask them about some kind of emergency help or advice. Social isolation is very important, and it also affects the somatic condition of the caregiver and increasing the intensity of their condition. So the question is, home or institution? And if something between, where is that place? Where is the place for the patient and their caregiver to, let's say, make them both happy, but in fact make them feel safe? So there's a list of things that should be introduced when you integrate outpatient care or ambulatory care. There are more and less obvious components. Home visits and phone advice on the phone, the consultation on the phone. This is not something very common in Poland. Personal support to the caregiver at associations, or perhaps long conversations with doctors who have the time to explain some of the doubts. It is also about sensible, not excessive drug treatment. And there is a big problem with that related to institutions. In home care, the number of drugs, of medication in Poland is between 3 and 7. In institutional care, there's more than 10 different drugs. Why? Because the organization is not well developed. The various structures that we have in Poland have their consultants, and these consultants are neurologists or psychiatrists, sometimes other specialties. I'm only talking about patients with dementia. So these two fields are the most important. But what does it mean? It means that in the short term, we solve the problem based on the symptoms without thinking about the holistic aspect of the patient's functioning. Not only in Poland, but in absolutely all countries where patients are in various institutions, the overuse of sedative drugs and antipsychotic drugs. It is a pan-European problem. It is a problem that has been discussed 1 year ago at Alzheimer's Europe. And there's a problem with coordination of treatment of polymorbidity, polypragmasia. So, well, we have different types of dementia. It doesn't mean that the rest of the body is doing well. We have hypertension, we have diabetes, we have malfunctioning of various organs, and this requires many different specialists to treat these patients. So this paints a certain picture. So in general, let's call it deinstitutionalized institutionalization. Sorry about that expression, but the home is a central place. There are such centers and models developed elsewhere in the world, like Australia, and they are doing well. The problem here is that the home requires a very mobile and competent personnel, because it means it is about providing care to both the patient and their caregiver. This means that the caregiver and the patient can receive all possible help from providing food, from providing medication, dressings, consultation, stimulation. So this is the first circle centered around the patient and their home. The second step is to develop institutions that are not 24/7 institutions. Those are daycare centers, night care centers, relaxation or leisure or weekend care homes. So this is where the caregiver can send the patient when needed. There were some attempts in Warsaw but their regulations were hampering the invention of the social care home directors, their invention and their initiative. They accepted individuals for short-term stays, like 1 or 2 weeks. And such a model does exist in various countries, and it does work, and it works well. You can always say, that it can have a negative impact on the course of dementia, and it can accelerate the development of dementia. But if it is a place, a facility that is well combined with, like a daycare center, with some short stay accommodation for a week or several days, then it is not a big shock for the patient. So the home is a very central place. Home instead of all these other things, but it requires a completely different organization of care, and it requires money, because around the home there will be people who will have to receive good wages. Please take a look at these different ideas, different types of how to provide care and where to provide care. I would list not long-term care institutions, but assisted living, protected living. This is a very extensive concept or extensive bag. What is assisted or supported living? It looks different in large cities and in small towns. And in some countries like the Netherlands and Belgium, there is protected or assisted living between towns and cities. So there are complexes, there are centers with treatment, care, and the patients are not alone, because in assisted living they live there with their caregivers, and the caregiver can ask for help at any situation. So there is many different types of care, and we can move on to our 19th or 18th century structure. 1706, where in Krakow for the first time the monks opened the 24/7 care center or care home. So we are moving back several hundred years, and we continue what has been developed over the 200 years. So care that is mostly provided by nurses and their assistants. This type of care is not efficient, not effective enough for various reasons. The nurses are not sufficiently trained with regard to understanding the course of the disease. There you can see there's various types of complaints, the unpredictable course of dementia. There are various factors that can affect it, and the nurses are not technically prepared to cope with that. They call the doctor adds more medication, and it gets even worse. There is insufficient training together with caregivers at home. This has been already improved in the UK because it used to be much worse. The caregivers are often unthankful. They behave in such a way that caregivers go to a nursing home. They say this hasn't been done. How do you talk to the patient, and so on and so forth. So the nurses simply cannot stand it from the nervous point of view. So it is about having enough well-trained personnel and increasing the salaries. That is obvious. What are the threats related to institutional care? You can read it here on the screen in Polish, that there is no personalized care. We have these booklets called "This is me," who I really am. This is about you shouldn't give scissors to a university professor. They will not do it. But they will be a difficult patient. They will be hard to cooperate with. So doctors, physicians, geriatrists, gerontologists who deal with elderly people, pharmacotherapy, excessive pharmacotherapy should be controlled. And immobilizing patients should be an absolute exception in case of dementia patients. Treating polypragmasia, polymorbidity, strictly following the hours, the visiting hours, and splitting it. Half of the time is for the work of the personal, and then half of the time in the afternoon is devoted to the caregiver, who should take over the care, and then overuse or abuse of power and neglecting patients. So finally, let me say that the future of long-term care in dementia is doing well because we managed to find the middle ground, the middle way. This home doesn't have to be in a central place. It can be in a central place, in a central location, up to a certain point, and afterwards various structures can take over its functions. This is the way it is changing. And then it is a great support for the caregivers, and for the institutions, it is not an excessive burden. Assisted or supported living is one of these options in various forms, from living together with a caregiver under the supervision of a certain, let's say, municipal structure, to protected or assisted living where the caregiver moves together with the patient, or the patient themselves move for a certain period, like in Scotland, where there is an obligation. Every 6 months, the patient has to spend 2 weeks under the care of the state for the caregiver to take a rest, to avoid burnout, to carry out, to refurbish their homes, and so on. So thank you very much, and let me leave it here on the screen as the form of questions, how to find the Polish way in this. Thank you. Thank you very much, Professor, and let me open the discussion. We have seen a completely different perspective, and perhaps because I'm a doctor, but after every lecture I always think about what I remembered from the lecture, and I wrote down something very important. If something is happening, you call a doctor, and then it only gets worse as a result of the doctor's actions. So I think this highlights that we need an approach that is not purely pharmacological. This is something that the patients don't understand, that this is one of the first steps that we need to take. As the professor has said, some things were impossible despite the goodwill of the director of an institution because they were limited by regulations. Do we have any questions? We'd like to encourage you to ask questions, but if there are no questions from the floor, let me ask a question. We looked at the long-term care in the US from the point of view of a team. It was emphasized that the pharmacist is in touch with the nurse and the physician. And when talking about the support for the caregiver and the patient, the doctor who doesn't help because they prescribe additional medication, how do we see the role of specific members of that team? Who in this complex network of support that we do not have, but we should start building it, developing it, who plays the key role here? Is it the nurse or is it the medical caregiver? How should we see it? If we were able to do everything, if we did not have any limitations? It is a difficult question indeed. The answer is very simple. Everyone. But we do not have such a tradition. In Sweden, it's done like that. The whole team convenes, they meet up, and they discuss every patient. and they discuss all the pros and cons of their functioning. They are looking for answers to difficulties presented by the patient. They assess the type of care, and it doesn't matter whether the patient is in a care facility, a care home, or in their own home. It is about a certain consensus and understanding the role of the patient as the central person. So first, dignity and respect for the patient, facilitating everything for them, then the caregiver and possibly other people and facilities. They've had these experiences since the 1970s, I think. It was the first time I visited them. And since the 1970s, they made this discussion much more modern. It's not about discussing impossible things. There's a very pragmatic approach focused on the things that we can still do to improve the situation, things that we can do to make the patient function better, to prevent irritation, fear, and lack of security, the feeling of security. So in this discussion where we have a psychologist and a neuropsychologist in their diagnostic role, a physician, a nurse, and a rehabilitation specialist, in such a team, various viewpoints and various aspects of the patient's functioning are discussed. You yourselves wouldn't like only a doctor to deal with your life, or only a nurse, or only a rehabilitation specialist. It wouldn't make sense. Humans are very complex structures, and they require various types of assistance. So this is my answer here. So I think the message is that the thing that we should start with, and we tend to forget, is asking the question, what can we do for the patient to function better at their own home? Thank you very much.